All right, we should be good to go. Let's see, share with you. All right, are you able to see, Jimmy?
Yes.
Great. All right, so today I'll be talking a little bit about HDR interstitial brachytherapy, given that that's something it seems like we'll be picking up here at UTMC soon, and that it's, kind of new to me at least. So I thought it'd be good to give a little presentation on this, just some of the background of the clinical evidence behind when to use it and how effective it actually can be. So specifically, yep, an evaluation for head and neck patients, focusing on one paper from India. So we'll get right into it. So Balavat and others wanted to determine if interstitial HDR brachytherapy should have an increased role in treating head and neck cancer. So this is basically a retrospective analysis they did of something like a decade of treatments they had done in order to see like how effective this is, how their results compared to previous results they had seen in literature, and they wanted to more or less bring new attention to using this technique if it could be beneficial for some patients because it had kind of fallen by the wayside. These interstitial brachytherapy treatments have become a lot less common in the years. Like really the bread and butter of what we still see is these sort of HDR for gynecological cancers and prostate seed implants for prostate cancer. So something interesting here is head and neck cancers are the most common type of cancer in India. So a third of all cancers, and this roughly ends up at 200 to 250 cases each year. So if there's anyone to learn from, it's probably a group from India where they're seeing a lot of these head and neck type cancers in terms of how effective this could be. The majority are actually locally advanced. So 80 to 85% we're seeing in the stages where you, as we get into it, really wouldn't be considering the HDR interstitial as much. Part of this could be, I was talking just with Dr. Pearson earlier, popularity of chewing tobacco type products in India or other things. Pollution is also a contributor. So these sorts of issues are what make it so common. And most patients receive a combination of radiotherapy, surgery, chemosystemic, depending, on the workflow we go through of whether or not the patient is operable and if we need to do some sort of radical radiation treatment or some salvage treatment, et cetera. So getting into the basics of staging, sounds more intimidating than it really ends up being. This American Academy of Otolaryngology has a really good just sort of template to follow for clinical indicators for what would be a different stage. And I'll just go through one example because there's a whole huge manual for a bunch of different like sites and types of cancer. So let's just say it's in one of the salary glands. So TX, anything with X is the primary tumor, couldn't be assessed. 0 would be no evidence of a primary. T1 is less than 2 cm of the greatest dimension, and there's no extra parenchymal extension. So it's not extending outside of the salivary gland that it originated in. T2, tumor greater than 2 cm, but no more than 4 cm in the greatest dimension. Then again, up to T3, as you could probably imagine, greater than 4 cm and or having this extra parenchymal extension. So T3 is determined by size or how likely it appears it is to invade neighboring tissues. Then we start getting into the T4s. So T4A, moderately advanced local disease. So this could be tumor invading the skin, mandible, ear canal, and or facial nerves. So again, these neighboring tissues running by parotids, for example, one of the more common ones we see. And then T4B is very advanced local disease. So this is invading farther away than just a salivary gland. So this would be invading the base of the skull, the pterygoid plates, or encasing a carotid artery, starting to cut off that blood supply to the brain. Now, regional lymph nodes, again, X, it could not be assessed. And 0, no regional nodes. And 1, metastasis in a single ipsilateral node, 3 cm or smaller. So it's not invading the opposite side of the head, really not showing that it's super aggressively spreading yet, but still a nodal metastasis. Then we start getting into N2, where there are 3 subtypes. We could have a metastasis in a single ipsilateral lymph node that's smaller than 6 cm. N2B, metastasis in multiple ipsilateral lymph nodes, none more than 6 cm. Or N2C, metastasis in bilateral or contralateral lymph nodes. And then escalating all the way up to N3 for nodal staging, metastasis in a lymph node more than 6 cm in the greatest dimension. So another way to look at this is a recent case we had here where Dr. Hadzi was going to determine her fractionation based on how far away from the primary it had spread. Curative versus palliative treatment is kind of indicated where if you're starting with something like base of tongue or like a parotid gland, if you start getting below the clavicle, that's when you start considering, okay, this is like really invading quite far. We're going to have to approach this with a more palliative type treatment instead of an aggressive curative intent treatment. A designation of U or L indicates that the nodes are above or below the cercoid cartilage. So just as you're contouring a trachea, that prominent band of cartilage that you see roughly where you start your contour is another possible indicator you could see if you're reading some medical document, like in the patient's med records. But anyway, then starting to get into these distant metastases. So again, it's just kind of a binary test for this one, more or less. Okay, did this make it into the brain? Did this make it into some non-lymphoid tissue that would be connected to the lymphatic drainage of the neck, something like that? So again, yeah, if the disease has gone far enough away is where you really start to consider this part of staging. So one rule, so M1, where you have these really distant metastases, that's always going to be stage 4C, but just a little table of clinical staging based on the nodal involvement and how large the primary itself was to give you a general stage 1, 2, 3, or 4. Staging more or less runs on this scale of 0 to 5, 0 meaning there's nothing there, and 5 meaning you're dead. So once you start getting in the stage 4, these are like these terminal illnesses that are really unfortunate to see. So getting into more of what the paper was looking into, early stage cancers, so like T1N0 can be treated with brachytherapy alone based on previous studies that had been done, external beam alone, or external beam with a brachytherapy boost. Large lesions, T2N0, with high nodal spread potential, usually receive radical external beam or moderate external beam with brachy boosts. So as you start to escalate, you get less likely to be employing brachytherapy for the whole treatment. And then chemotherapy allows advanced diseases like T3N+, but not an N2A, to be treated with brachy after the tumor shrinks. So because chemo has gotten good to the point where it can really target that more distant disease, we could really focus in on what we want to be treating. We shrink the target of what we want to be treating. We can implant these needles and really get after these diseases. So we know external beam treatments can affect the parotids, salivary glands, mandible, and muscles of mastication, so your chewing muscles. And what this paper wanted to try to compare was their clinical experience versus that of the literature in as far as like how many of these like kind of more morbid aspects, these side effects of the treatment, they're going to see compared to what they had seen cited in the literature. So brachytherapy is intended to minimize these effects because we get this tremendous fall off, that we're able to place the source directly in what we want to be treating. Hopefully we can avoid these effects to other things. So again, we've seen increasing use in gynecological malignancies in recent years, but decreasing use in head and neck cancer. Part of the reason could be that people aren't getting trained in this as much. Part of the reason could be that patients are more hesitant to have an invasive procedure repeated over the course of a week as opposed to a non-invasive procedure that they just need to lie down for. The dosimetric impact would have to overcome several drawbacks. I'll get to these in a second. So again, lack of experience or expertise. Not a lot of physics teams and physicians would be confident enough to do this sort of implant. There's complex application, particularly in terms of injury to vital vessels of the neck. So if the cancer is located near where the carotid arteries are running, you need to be really confident that when you're putting in these applicators, you're not going to nick the carotid artery and have a really unfortunate case of bleeding on your hands. So you really need to know what you're doing. Also, you have this sort of curved patient anatomy, particularly if we're getting in something that's down near the like curvature of the chin, going from the side of the face to below the chin, and more complicated dosimetry because one example in this paper was a whole grid of needles that were inserted like in the underside of the chin. Jimmy, I don't know if you can see me still while I'm sharing the screen, but it basically would go up through the like floor of the mouth into like the base of the tongue, and there was a whole grid of these that were implanted. So you start to get more complicated administrations than like a 3-channel, 2-channel gynecological cancer case. So now, for this format of the study, it was a retrospective study of 58 patients, all having squamous cell carcinomas. So they had the Karnofsky performance status greater than 70. So they're capable of caring for themselves, but 70 being the lower end of this is you're not capable of normal activity or work. So perhaps if your disease is kind of like impeding aspects of your life, but you're still able to care for yourself, that or better is what would be included in this study. For like a reference, the Karnofsky scale is like a 0 to 100, and 20 and below would be you need immediate medical attention. You're like in the emergency room or on your way there. So anyway, they had 46 external beam with brachytherapy boosts and 16 treated with brachytherapy alone. Again, kind of showing the breakdown of a lot of the cases they're seeing in India. They're not catching early enough to have a huge amount of these just be treated with brachytherapy. These really early stage T1N0 type cases, but a good portion of them they're catching at T2 and able to treat with a brachytherapy boost. Now, just a little breakdown of who the patients were. So much more likely to be male, median age of 56, ranging from 27 to 81, 27 very early on there. But basically, we can see the breakdown of the locations. So lateral border of the tongue, that just makes me in particular suspicious of some sort of like tobacco use, but like chewing tobacco in particular. Then quite a few oropharynx cases in general. But as we could see, perhaps more interesting to what we're thinking about and when we'd want to be applying this types of treatment. So really the T1, not too many, only 8 of the patients, that's 17%. T2, they are catching a decent amount of these head and neck cancers by the time it gets to that stage. So if what we see here is at all similar to what they were seeing in India, and which, you know, that's a big if because of screening differences we could have between here and there, differences in lifestyle choice between the patients here and there based on, you know, how prevalent chewing tobacco may be in that country versus ours. We could be seeing more brachytherapy boosts if the study is any indication, but, you know, hands in the air. Yeah, so moving on from just the general overview of the patients involved in this study. So they had external beam using a Siemens Encore expression machine. So this was a 6MV machine. So using a 3D conformal, that's a capital 3, which makes a number sign. So I'll have to go back and change that when I upload this to the resident folder, or IMRT. So they had 2 gray fractions 5 days per week. That's sort of more typical fractionation we'd be seeing for head and neck type cases. They were assessed for response based on clinical evaluation and CT prior to the boost. So this is for essentially to see if they want to continue with a brachytherapy implant or not based on how the tumor is responding. Brachytherapy implants performed under general anesthesia. So they have stainless steel needles that are generally 14 to 16 millimeters apart, they're saying, and spread out in order to cover the target. Then a plastic catheter is threaded through each needle. The needles are then removed, leaving the catheter held in place by plastic buttons, and they aim to treat a 10 millimeter margin around the target. So again, really keeping this dose in tight towards the parotid gland or the base of the tongue or whatever the target may have been. So they would have CT scans after the implant procedure with IV contrast used when the carotid vessels were near the target. So again, something we could be seeing is more contrast used in these based on what I've seen at Flower recently. Just a water equivalent calc is usually good enough unless you're doing something with like a shielded applicator. So the IV contrast really shouldn't mess with your dose calculation much. The Flexiplan Electa system was used to generate these plans. So these boosts are 3.5 to 4.5 gray per fraction determined by site and status, but in general, the median was 10 fractions treated bi-daily, 6 hours apart. So we could be seeing patients coming in the morning and at the end of the day for these types of boosts if this sort of regimen is followed. Prescribing to D90, so again, a difference from these gynecological cancers where you're usually looking at point A first and determining how hot that plan really is based on the dose to the surrounding organs at risk, based on what sort of coverage you would want to point A. Another metric they were using at Flower Hospital is this sort of D90 when these brachytherapy plans start to get a little too hot if we're scaling to prescription value at point A. So prescribed to D90, the median gap between external and implant was 21 days. So the patient is given some time after this external beam treatment. Their inflammation gets to go down, their body gets to recover a little bit before they're getting this following invasive procedure. Now, here is an example of the catheter placement. So again, going through under the chin, through the floor of the mouth, towards the base of the tongue here. And you can see there are quite a lot of implants used to cover the target in this case. And they place these caps on the end of these catheters. So I'm not sure if this is standard or if this is just what this center was using, but that's quite a lot of like plastic BBs to have like resting on your tongue in the back of your mouth. I can imagine that's quite uncomfortable. So the patients that choose to go this route would really have to benefit from the fall off in terms of like avoiding like really bad xerostomia or something like that. So again, they tracked a biological equivalent dose in this study to keep total dose within tolerance. They were kind of vague about what that meant, but they essentially tracked BED to as one of the main determinants compared to like the median value for a given type of case to determine when side effects were more or less likely relative to the median of what was prescribed. So again, here are the sort of median and mean values for BED and equivalent dose in 2 gray fractions for the 2 treatment techniques, external beam and brachytherapy alone. So you can see when you're doing brachytherapy alone, again, this is a very different technique using brachytherapy as opposed to the external beam. But again, these are much lower stage cancers they're treating. So they're treating with a lot less dose than the external beam plus brachytherapy together. So unfortunately, they didn't really break down like a specific patient case in terms of, okay, we saw this staging in this site, and that indicated for us to use this dose. So I can't really provide that to you today. So they just more or less gave ranges of what they did for the patients. And that's really kind of limiting in terms of what we could tell in terms of like a standard fractionation or treatment scheme we'd be seeing here at UT if we start doing these here. They were seeing anywhere from 21 to 65 gray external beam, followed by 9 to 41 gray boosts. That just seems like a wild range. It seems like if we were to take what we see here, we sort of see these like 70 gray, 66 gray, 60 gray target levels for head and neck type cancers, more or less. So it seems like instead of doing this simultaneous boost to the highest risk target, some of them, if they're treating to 65 gray and then following up with like a 9 gray boost, let's say, that's more akin to what we're doing with external beam, more or less, in terms of dose levels anyway. But that's just conjecture on my part here. And then the brachytherapy alone was anywhere from 16 to 53 gray. So D90 was getting 4 gray on average. The V100, V150, and V200 just sort of give you the idea of how uniform these plans are, which uniformity is thrown around a lot when we're talking about brachytherapy, but in my head, it just always comes with an asterisk because it's brachytherapy. Of course, it's going to be very hot right next to the seed. It's not going to be a particularly uniform dose distribution. Something interesting we could keep in mind if we start seeing these types of cases here and want to have some sort of comparison towards literature is sort of like we do for stereotactic patients here, compare dosimetric indices. So the homogeneity index and the dose non-uniformity ratio are two fairly common ones you'll see in analyzing brachytherapy plans. So the dose non-uniformity ratio is the simplest one, just comparing the volume at 150% dose and the volume at 100% dose. The homogeneity index, it depends whose definition you're going by. There are multiple definitions for homogeneity index. Some of them, I think ICRP, if I can't remember, there's like an external beam definition for homogeneity, but that's not so much applicable here. There's also homogeneity index defined a couple different ways in different brachytherapies papers I found, but in this case, we could just consider homogeneity in terms of the dose to like 5% and dose to 95% of the target compared to the prescription dose. So local control and recurrence is in the table on the left here, and disease-free survival is tabulated on the right. So if we're looking at the T1 and T2 cancers, local control was achieved all of the time for T1, no matter which approach they were going with. For T2 cancers, it starts to get slightly more questionable, and they don't really have enough to have good statistics, I would say, for the brachytherapy alone here. But in general, they're trying to show that brachytherapy alone, despite the small sample size, is at least trending with or slightly better than the external beam with brachytherapy boost. But again, they're mostly using brachytherapy alone for lower stage cancers. So kind of really hard to make any solid, concrete conclusion there. Just comparing here, we have the disease-free survival based on the biological effective dose and the equivalent dose in 2 gray fractions on the right here. So in general, when you're giving more than the median biologically equivalent dose, you are giving a better chance at disease-free survival. So perhaps indicating if they were to use this retrospective analysis in their clinic, they should say, okay, maybe we should favor towards hotter plans if we're ever on the fence, just because as we get into a few later slides, the only caveat to that is whenever they were above the median biologically effective dose, that's when they started to risk some of these side effects from the radiation. So anyway, yep, just a general trend of the more dose leading to much better local control. It's, again, hard to say because smaller numbers, but the separation between these two is pretty large in pretty much every case. So again, this is local control by treatment site. So again, lateral border of the tongue, hard palate, soft palate, these sorts of treatments where they're implanting through the base of the mouth is where they're most commonly using these brachytherapy cases, and all of those worked fine. Perhaps some of the trickier cases would have a lot less patients involved, so we'd probably have to go back and see those. Like I doubt that buccal mucosa, kind of like the inside of the cheeks, I doubt that's just some sort of death sentence, but it seems like the patient who had that was less effective. But anyway. And then here we just have survival outcomes based on size and staging. So local control, local recurrence, regional recurrence, and local regional recurrence are all plotted here. So again, local control, quite common for these T2 cancers that would be treated. We really only start to risk recurrence if we're looking at just staging by the time we get to these stage 3, stage 4, which brachytherapy is less applicable to these sorts of treatments anyway. Really, you'd have to have some aggressive chemo to try to zap the cancer in order to consider someone that's a stage 3 for a brachytherapy boost. So anyway, so this was external beam with brachytherapy boost, and this is brachy alone. So again, much less statistics. The mean doses are a lot lower, but local control is achieved similarly to what we could see with the external beam and brachytherapy boost. So again, moving towards these sort of side effects that I've been mentioning throughout, osteoradionecrosis only developed in one patient of the 56, I believe, that they had total. They claimed no other significant late toxicities. They had acute toxicities of infections in 2 patients. So that's just going to be related to the fact that this is an invasive procedure. You're placing physical sources into the patient. They need to remain there for a long time and not get infected. You are running something of a risk of infection when you do this procedure. They noted that there was no bleeding listed in the same sentence in these toxicities. So I just take that to mean they weren't sort of clipping any major blood vessels. Obviously, I imagine there's some amount of blood no matter what when you're doing something this invasive, but nothing that persisted after the original implant procedure or failed to heal after they removed the catheters from the patient. So in terms of late toxicities, there was soft tissue necrosis in 2 patients. So that's when these doses start to get high enough, the tissue goes necrotic. So local control rates for T1 and T2 cancers were quite high. 5-year overall and disease-free survival was on par with literature that they were citing. Other studies, just to give us a larger sample size in terms of the types of side effects we'd expect. So some transient bleeding, infection, again, invasive procedures. These are to be expected in some number. Soft tissue necrosis and ulceration can occur in 7% based on another study that was referenced in this study, and osteoradionecrosis. So this is, again, particularly when you're near the mandible, you just need to be careful. This paper cites that exceeding the median biologically effective dose of 88.95 gray for external beam with a brachytherapy boost required for certain cases caused the 2 of 58 with soft tissue necrosis and 1 of 58 cases with osteonecrosis in the study. So again, once you start exceeding these BED values is where you have to really be concerned about the exact placement of your dose relative to these nearby healthy structures. So overall, the authors claim HDR treatments can be effective when treating low-risk head and neck cancer patients. Despite the low statistics, I would say that seems to have held true based on their analysis. The experience of the team may be a limiting factor they highlight, which is part of why they wrote this article, to kind of raise this as a possible solution. If the team is practiced enough, it can, effectively treat these low-stage cancers. But obviously, you run more of a risk, particularly in these cases where you start to get above, for example, the mean BED in this study. You really need to know what you're doing. Otherwise, you could have a much higher risk of osteoradionecrosis than this study would have had. And obviously, you need patients to be willing to undergo an invasive procedure to conserve some of these functions, particularly considering xerostomia. This study didn't mention a single patient having xerostomia afterwards. So I thought that was interesting. Local control was satisfactory for T1 and T2 patients. Again, only 3 toxicities in these sort of more difficult cases where they needed to be more aggressive with their dose. HDR can offer better local control than external beam with acceptable toxicity, is another claim of the paper. Again, I kind of think it's hard to make an apples to apples comparison just because they seemed to be laying external beam with brachytherapy boost in comparison to brachytherapy alone. But the indicators to be included in one of these two groups was how advanced the disease was in the first place. It just kind of seems to be not an apples to apples comparison. I don't think they did a very good job of comparing, okay, if we just treated this head and neck cancer with an external beam plan, what would we have been able to accomplish? And they didn't really provide a dosimetric analysis of here's what we would have done even though we treated this patient with just the brachytherapy. If we had to do external beam on this early stage patient, what would that have dose distribution look like? They didn't really get into anything like that. So we're kind of left guessing what would have happened, which is, I think, one of the more unfortunate things of this study, but could be in future work of theirs. And here are my 2 references.